Ponseti itself has a huge learning curve, and like we say many times, dil hai mushkil. So it's good to think that the technique is easy, but when you actually go into it, you realize that there are many things that one can go wrong. So let's see what commonly goes wrong with people who don't really do Ponseti casting too often, and even in our own hands, we've had this before. So, for example, let's take this case of a 3-month-old child who came with a club foot, treated properly by serial manipulation and casting. It took longer than expected. About 9 casts were applied because the cast had slipped 4 times in between, and the surgeon had to start all over again. So, what happens here is that the deformity persists and it has failed to improve over the last few casts. And the only reason that it has failed to improve is because surgeon has failed to realize that what has gone wrong over here. So this, to my mind, make no mistake, is a typical iatrogenic clubfoot, which is known as an atypical clubfoot. It is very different from the complex clubfoot, as we'll see later. And the reasons for it are clear cut. There is too much padding applied because sometimes when you're a beginner, you may think that you don't want the plaster cast too tight and you don't want vascular problems. The baby may have been crying and fidgeting, so the cast is not really well molded, and the foot slips upward inside the cast and you don't even realize it, and hence the foot deformity may start looking worse. So how does this happen? You started with a nice supple clubfoot and here you are with an even more deformed clubfoot. So how will you identify an atypical clubfoot? So there are a few characteristic hallmark features like the plantaris, which I will explain, which is, I'll show you some x-rays and CT scans to clearly point out how it's different from a normal clubfoot. The forefoot here is in total equinus in plantaris, and the short great toe has actually cocked up because it is in hyperextension. And there is an apparent tibial bowing because there has been an abnormal force which has got exerted at all the wrong points inside the cast. So you have ended up causing a midfoot break, you've ended up causing a almost squashed foot and a squashed heel, as you can see in both these pictures here. In addition, there are some very, very clear-cut features you will see, like a rigid equinus and a completely squashed heel over there. You can see a flattened heel pad there. A deep crease above the heel, as you can see here, both on the dorsum and on the plantar aspect. You see a plantar flexion of all 5 metatarsals here, which is the plantaris, and the transverse crease on the sole of the foot and a short extended, hyperextended first toe. So to show you that these creases, these pressure points, and this very, very deep crease over here, sometimes it goes all across to the medial border. And you can actually make out in this that the forefoot has actually become hyper abducted, whereas the midfoot and the hindfoot have lost really their alignment with the rest of the foot. And this happens because the foot is not really abducting through the subtalar joint when you're exerting abnormal pressure or your pressure at the wrong point, because in Ponseti it's very important where the pressure should be exerted and what the foot should pivot around. So therefore you get an atypical clubfoot. So if you can see here, to show you again another child with the deep medial crease growing right up to the medial border there, right across the midfoot. Again, to show you the edema on the dorsum of the foot, which means that the skin, the soft tissue, the muscles, everything is inflamed over here. And you can see some pressure marks developing out here and erythema on the dorsum of the foot. So when this happens through your clubfoot journey, what should you do? We'll take a look at that shortly after now examining. There are researchers who have gone into x-rays and CT scans to show you what is happening inside the clubfoot. As you can see here, the heel is not corrected. There is a clear-cut midfoot break. There is a toe crowding of all the 5 metatarsals, and all of them are in a very deep, sharp equinus there compared to a normal normal foot, which is in the X-ray below here. Again, image intensifier images to show you the same thing which you saw on the earlier X-ray, the heel in equinus, midfoot break, and a deep plantaris. And this is a normal foot. So you can compare how badly this has been quashed inside the plaster. And a 3D CT scan to show you the same thing. If I may orient you, this is a lateral view, and this is a view from the posterior. So you see here that the heel is still in equinus and disconnected. And all 5 metatarsals over there have virtually taken an 80-90 degrees dip in equinus, which needs to be addressed first when you're dealing with the atypical clubfoot. So the first and foremost thing that you will do is leave the child without a cast, which is known as a cast holiday. So stop casting for a few days. Sometimes you may need to do that for a few weeks. When will you decide what's the end point of stopping casting or to resuming a new set of casting? The end point is defined as till the great toe actually becomes longer, the heel is the great toe is no longer appearing contracted, and the child has started moving around a bit, and some mobility has been restored, some skin changes have started coming, and it starts looking normal. After then, you will start manipulation using a two thumb technique, which I will show you in figures as well as in a short video. So this is how you see the skin changes have all gone. This is restored and it's looking supple as it were before. The foot is of course looking shorter here, but the deep crease over here which you saw has started disappearing, and even the roundedness of the heel has started coming back. The great toe has started looking straighter. This is how now, when compared to the normal foot, the foot should start looking. Then you resume the Ponseti casting all over again. But now you will adapt your technique. And how is that? You will stop abducting the foot. You will allow the foot to relax back for some time and then work on the dorsiflexion only, because that is where the problem lies. The pathology now is in the forefoot and just gone into severe plantar flexion, the plantaris, and therefore you need to start bringing it back into dorsiflexion so that it aligns with the midfoot now and comes in one axis. How do you do this? How do you correct the plantaris? You dorsiflex the first and the fifth toe together. So if you see both the thumbs here, they are pressing equally. In a routine Ponseti, you give pressure only on the ball of the great toe to eliminate the cavus. In a plantaris, you will give equal pressure on the ball of the great toe as well as the little toe. And you gradually bring it back, and this crease starts opening out as you can see out here. Then you dorsiflex and dorsiflex gently, just enough, sometimes in a couple of casts before you get it restored into full abduction. When the abduction stops, sometimes you may have to do an early Achilles tenotomy. In fact, don't aim for too much abduction at all over here. Once the deformity is corrected, you may require a modified FAB, or you may actually require to give a AFO. And in some cases, we've even continued a couple of casts after the tenotomy, and that is well known. Once your equinus, the dorsiflexion is corrected, the equinus is corrected, then you may give a little more abduction. So if I could quickly show you here the technique by a video, very, very gentle manipulation, just restricted to the forefoot, pressure on the great toe, pressure on the little toe, and just enough to maintain it in bring it back into neutral. Again, the same manipulation being done over here, and hold it for some time. It's important to let the soft tissue settle down there. And as if you can watch the video here, there's absolutely no manipulation being done to the midfoot or the hindfoot. In fact, the tailor head is covered. You can still see the great, the first toe little in adductus. And when you're doing the casting, again, remember to maintain the pressure, as you can see, equally on both the feet. Mold your cast well, mold the arch of the foot, and carefully improve the dorsiflexion. Another tip here is to maintain, when you're going above knee, mold behind the knee very well, and the thigh, so that the cast doesn't slip off all over again. And a little bit of hyperflexion at the knee also has to be done. This has to be extremely gently done with a nice quiet baby, and focus only on correcting the plantaris, then go into early tenotomy, and then go into a abduction if need be. So if handled well, an atypical clubfoot also can be restored back to normal, and these are some of the results post-treatment: fully corrected, supple, and fully functional. Now this is very, very different. This is again a clinical picture to show you how well it is corrected, and complete restoration of all the tibio-talar axis, and both the feet are straight, the lateral borders are straight, and this is as good as a normal foot. And another important tip here is to, when you're giving the foot abduction orthosis, don't set the angle of abduction to more than 30 degrees of external rotation, as you can see out here. Normally, you try to give this angle at about 70 degrees if it's a unilateral club foot, and if it's a bilateral club foot at both sides 40 degrees. But in a atypical club foot, you will restrict your abduction because here the main goal is not to hyper abduct and cause a midfoot break all over again. Now, how is this very, very different from a syndromic club foot, or what is known as the severe or complex club foot? People get confused between the nomenclature of an atypical and a complex club foot. Remember, a severe or a complex club foot is ideally a syndromic club foot where you have marked supination. The calf is also very, very hypertrophic. The talus is extremely flexed and internally rotated. As you can see over here, it is virtually more than 180 degrees severe adduction and a cave is there. And the entire foot is hypoplastic, almost 1 centimeter shorter if it's a unilateral case. These children are syndromic. You should do a good general examination. They may have associated hip and knee contractures. Sometimes even in the spine, there may be issues. There might be hemimalias. There may be several other dislocations associated with that. So that is what is going to tell you that this is rigid and this is not going to be amenable too much to your casting. You may counsel the parents that they are very resistant and the cast may fall off after the third or fourth if not done well. So again, you lower down your goals and you restrict yourself to try and give only a few degrees of abduction. You may need an early tenotomy, but they also can be treated successfully if you adapt your technique well. You emphasize on dorsiflexion in it, and you do your cast greater than 90 degrees at the knee using flexion. So you use the similar principles to what you did in atypical club foot for successfully treating these syndromic club feet, because your basic goal is to get a braceable club foot, braceable foot at the end of your treatment. And traditionally, it has always been believed that these are going to need soft tissue releases or very massive surgeries because in most of these syndromes, the suppleness of the muscles or the contractility of the muscles, the excursion itself is limited. They have associated contractures, and hence there was a very high propensity to go towards surgery for these children. But at Wadia, we recently published one of the largest series where we have shown that it is possible to treat with the typical Ponseti technique, non-idiopathic and neuromuscular syndromic club feet. What did we do? We looked at two groups of patients compared with idiopathic feet and syndromic feet as regards to age, the Pirani scoring, which was noted both pre and post casting and at follow-up. We studied whether they required higher number of casts and what was the tenotomy rate in them and what was the brace compliance. And outcome measures were whether we had a good success rate comparable to the idiopathic club feet, what was the failure rate, whether any secondary operative procedures were needed. If so, then what type of secondary operative procedures were needed, what was the follow-up and recurrence rate. And this is what we found in our study, that we had almost 146 in the non-idiopathic group, 146 feet. We saw that although our age at presentation, the mean age was higher, the initial severity of these syndromic feet was almost comparable to the idiopathic club foot. The total number of casts required were of course higher. We had a very comparable follow-up, and we found that we have a very, very good initial successful success rate, and the need for tenotomy was also as much as the idiopathic group only. But however, what is significant, and this was a significant p-value, is that syndromic feet will tend to have a higher relapse rate. So you have to be alert and ready to manage them, and you may need to use limited posterior releases or at times fixators if a recasting does not work in non-idiopathic club feet. However, your first line will be to go back to the casting by Ponseti technique, and only where it fails, there you will use surgical methods. How does our study compare to the literature? It's almost at par with the rest of the world literature, except that our mean age was higher, our follow-up was almost equal, and our initial success rate was as much as any other paper, in fact, better than some series. And relapse rate was as expected as compared to other series, but it was significantly a larger sample size. And hence we concluded that it can be successfully applied to idiopathic and non-idiopathic and syndromic club feet, but with caveats like For example, this 5-year-old child now, who was initially Freeman-Schendel syndrome, treated with a typical Ponseti, came back with a relapse, had to be recasted, and yet she relapsed again. And there we had to just do a limited posterior release, as you can see from the scar there. But she achieved beautifully plantigrade and functional feet at the end of a 4 years follow-up. Here again, a MMC 8-year-old child with a 4-year follow-up. In this condition, there is hardly any muscle power there to maintain your correction. Hence, although treated with casting, this child had to go an early tenotomy, and with the casting, Ponseti casting itself, we were able to maintain him on a 4-year follow-up. So the message that I would, another AMC child with a CTV and a CDK and hand contractures as well, treated with Ponseti casting, relapsed, and again came back with treated successfully again with the Ponseti casting, and that's her follow-up. So even relapses in these syndromic children can be recasted and they can do well. If they do need surgery, then the amount of surgery or the morbidity associated with it definitely decreases. And by far, there are very, very few conversions into open surgery needed for these children. The Ponseti technique in non-idiopathic CTV does have good results, so you should use it as your second line of defense as well. This was one of the largest prospective series from a single center. I would recommend it, despite an older age group, which is very common in our country. You can get very, very excellent primary and secondary results. And recurrence can be definitely treated by a simple tenotomy and recasting. So hopefully, we will need lesser and lesser extensive surgery for syndromic club feet if we just modify our technique as I showed you for the atypical club feet.